Hello and welcome. Today we are going to discuss about gestational diabetes mellitus. Any degree of glucose intolerance resulting in hypoglycemia with the onset or the first recognition during the pregnancy is known as gestational diabetes mellitus. As you know, diabetes is a metabolic disease that there is an insulin resistance. So the blood has high sugar levels when there is diabetes. It happens in pregnancy due to increased hormone levels like placental lactogen, estrogen, prolactin, progesterone, free cortisol and growth hormone. So there is an increased resistance to insulin and maternal blood sugar will be increased. So maternal blood has more sugar levels and that sugar-rich blood will travel to the fetal circulation. In fetal pancreas, due to this increased blood sugar levels, there will be increased production of insulin and the glucose metabolism within the fetus will be high. So it will result in macrosomic babies. When we are discussing about the diagnosis of this gestational diabetes mellitus, there are screening tests and diagnostic tests. The screening test we are doing to diagnose gestational diabetes mellitus are fasting blood sugar levels, random blood sugar levels, postprandial blood sugar levels and glucose challenge test. In postprandial blood sugar levels, it is performed in all women in the booking visit as a screening test for gestational diabetes mellitus. If the value is more than 120 mg per deciliter, we can suspect GDM and confirm it by performing an oral glucose tolerance test, which is the diagnostic test. Oral glucose tolerance test, which is known as OGTT, is performed by asking the patient to fast for about 10 hours, minimally about 8 hours, maximally 14 hours we can on, and averagely we are fasting for about 10 hours. And we can do a fasting blood sugar and then give 75 grams of glucose, which is dissolved in 300 milliliters of water, to take within 10 minutes. Then the blood sugar level assessed after 1 hour and 2 hours. So the fasting blood sugar levels more than 100 and the first hour sugar levels more than 180 and second hour blood sugar levels more than 140 will confirm gestational diabetes mellitus. HbA1c, which is a diagnostic test, is the best test to assess the degree of control at the booking visit in those who are non-diabetic mothers. If the patient is well controlled at the time of the conception, HbA1c should be less than 6.5. GDM will affect to the fetus as well as the mother. In the first trimester, there will be fetal abnormalities, sacral agenesis, recurrent spontaneous abortions with the development of GDM. And in the second trimester, there will be polyhydramnios, large for dead babies, and fetal growth restrictions can happen with the development of GDM. In the third trimester, there will be intrauterine deaths, fetal malpositions due to polyhydramnios, and premature rupture of membranes and also preterm labors can develop with the development of the GDM. And also during the labor, there will be cord prolapse, prolonged labor, fetal distress, sudden intrapartum death, shoulder dystocia, and birth traumas can be happen. If the mother is having GDM, the neonate can develop hypoglycemia, respiratory distress syndrome, jaundice, and electrolyte imbalances. And also, GDM can affect the mother as well. So the effects of the mother will be pregnancy-induced hypertension, recurrent urinary tract infections, worsening of diabetic retinopathy, diabetic ketoacidosis, vulvovaginal candidiasis, puerperal endometritis, and lactation failure. Now we are going to discuss about the management of GDM. In the management of GDM, there are main two management options. The first one is the dietary control and the exercise, and the second one is using hypoglycemic drugs. Although strict dietary control is not possible during the pregnancy, The mother is asked to control their diet and also to engage in frequent exercises in order to control their weight. And also we can use the hypoglycemic drugs if the blood glucose targets are not achieved only by the diet control and the exercises. When the using of hypoglycemic drugs, we can use metformin alone, or we can use metformin adjunct with the insulin. When oral hypoglycemics alone is insufficient, human mixed start insulin is usually used to achieve the control. Usually, insulin is given 12 hourly. If mixed start is not available, we can use 3 doses of short-acting preprandial insulin combined with single dose of basal insulin at the bedtime. Fetal surveillance is very important in GDM mothers. Screening for congenital abnormalities carried out at 18 to 20 weeks. Ultrasound scan used as most of the abnormalities are structural. Ultrasound abdominal circumference is assessed at 28 weeks, 32 weeks and 36 weeks. If abdominal circumference is more than 90 centile at any stage, we should consider about the insulin therapy. Now we will discuss about the time of delivery. Well-controlled diabetic mothers can deliver the baby between 37 to 39 weeks and if necessary can go up to 40 weeks also. But if the control of the diabetic is very poor or the mother is having complications, the delivery should be done before 37 weeks. Also, the induction is the best method for the delivery. Cesarean section is also can be used only if there is a obstetric reason. Thank you for watching and we will be back with more videos. Thank you everyone.